Thank you, Dr. McLeod, and thanks also to my colleagues, Dr. Santiago, Dr. Randleman, for, I think, laying a fantastic foundation. Maybe I can trim about a minute off my talk, because you've seen a lot of fantastic supporting material. My disclosures are below. I do have intellectual property interests in some of the modeling and measurement applications that I'll talk about. So isn't LASIK already good enough? Why do we need to worry about biomechanical assessment or structural assessment? We're doing just fine. I think that's a common sentiment, but I think most of this room is at least curious about what biomechanical information might do for us. And I think one of the most compelling discrepancies that we see in our field is the difference between the precision of our preoperative assessment and our delivery, and then the connective tissue that connects a measurement to a plan. So we have extremely high resolution, three-dimensional corneal imaging capabilities you've heard about. We also have these exquisite delivery systems with femtosecond excimer lasers that can deliver a treatment that's ultra precise. But where I think we're lacking is in that planning process between the two. So we leave an awful lot of information on the table when we take a plan to the operating room. If we look at our current approach to treatment planning, most of it is retrospective based on historical outcomes. It's certainly probabilistic as opposed to deterministic. The models are statistics-based. They're helpful, but they're also minimally personalized. So the typical LASIK nomogram is sometimes an age, but most often just a refractive error and the device that you're using, and maybe a K value. But there's an awful lot of information that we're not leveraging. And this applies not just to LASIK, but to astigmatic keratotomy, to ring placement, and then to a multitude of new procedures, including lenticule extraction, tissue insertion or addition techniques, intracorneal rings, all of which I think we could improve the precision of the process by making the predictive models more patient-specific. So each one of these interventions ultimately appeals to biomechanical change, whether it depends on it or whether it's affected by it. And so why don't we have a common treatment planning pathway that leverages this biomechanical process? How can it help us to deepen our understanding of biomechanical assessment? Well, one benefit, I think, is improvements in the sensitivity and specificity of ectasia risk detection. So we certainly are, you can see there are a number of different approaches to understanding that, but a comprehensive approach that looks at the full 3D anatomy of the cornea might give us more information than a variable here and a variable there. Beyond that, once we decide a patient might be a decent candidate for surgery, how do we optimize their surgery and truly personalize it for their situation? There are two components, if we talk about structural assessment, to think about. One is measurement, and one is predictive modeling, and you've seen examples of both already today. This is an approach that we've been working on in Cleveland to modeling, and I want to thank Abhijit Singh Roy, REF07 for their years of effort on these projects. This is actually being translated into a commercial product that's owned by Cleveland Clinic. But the basic approach is to capture 3D anatomy with a standard tomographer that you would already have in your clinic, and then build a finite element model from that. And then you have to make some assumptions about the material properties. And ultimately, we should be able to measure those for each patient. But for most of the simulations, we'll assume a fairly generic, middle-of-the-road, middle-aged patient. And then what we do is take this finite element mesh of the cornea and build it into a whole eye model, because we found that the limbal response is actually fairly important in looking at the response to incisions and LASIK. We do a verification step where we load the eye with the patient's actual pressure and confirm that the eye has a topography very similar to the real patient. And then from that point, we can go forward with some confidence and simulate a procedure. And that's what this graphical user interface is all about. So it combines the demographic information from the patient uploaded from the tomography, and then the surgeon or technician can specify, which is where the name comes from, a particular treatment plan. And then the finite element model will simulate that procedure on the virtual eye. And you get a postoperative shape with stresses and strains. And then ultimately, we have to reduce that to something useful to the clinician. And this slide summarizes that process a little more intuitively. There's the measurement step, the software client that's attached to the device, and then a cloud-based server that runs the computational simulations and delivers a report back to the user. You've already seen some very nice slides showing you just how complex the cornea's material properties are. We have differences along the lateral dimensions of the cornea, as we see in this great study from Michael Smolik. that shows that the weakest part of the cornea tends to be the inferior part when you look at cohesive strength. And then this work that shows that the branching density of the collagen fibrils increases in the anterior cornea, and along with that, you see an increase in the relative strength. And you've seen that borne out already in this cohesive testing study that Dan Dawson, who I know is in the audience, and Brad Randleman collaborated on. A beautiful pivotal study that showed how the cornea, really, the stroma actually is much stronger in the anterior part than the posterior part. This is one of the rationales for lenticule extraction surgery. So it's very important to understand this and to measure it in patients. Brion shows a very similar trend with a different measurement technique that's non-destructive. And you've seen some OCT elastography examples. Again, lower properties in the epithelium, higher in the stroma, and then it decreases to the posterior stroma in normal eyes. And these are from an in vivo study. The math of capturing those properties can be complex. These are the strain energy equations that try to capture the fibril orientation. This slide is here just to make a note that we use a microstructurally motivated material property model to make these simulations run. Let's ask a basic question about LASIK. Back to the question of whether or not it's important to understand the biomechanics in a typical LASIK procedure for myopia. So this is a case where we took the same geometry from an eye and made the eye either weaker or stronger depending on the corneal material properties, and we used standard values from good experimental literature. On the left, what you're seeing is the deformation of a cornea that has a high stiffness that undergoes a 6-diopter LASIK. And what you're seeing with this arrow is that the apex of the cornea is actually displacing posteriorly as a result of the tissue removal process, and the limbus is moving outward. On the contrary, the weaker cornea, you see that the apex is displacing forward, and the limbus is actually displacing inward. So there's a warpage phenomenon that occurs as the stresses and strains redistribute after the flap and the ablation. Now this is going to have a different refractive impact. So you're going to have the 6-diopter effect of your tissue removal, but then on top of that, you've got some additional flattening effect in a stiff cornea, which could lead to an overcorrection. In the weaker cornea, you actually have a forward protrusion that's going to reduce the myopic correction to something less than 6 diopters. So you're going to get a relative undercorrection. So this is the take-home I'd like you to remember. If there's one thing you remember from this talk, a weaker cornea could lead to undercorrection of myopia in LASIK. And this is important because what do we do when we see undercorrections? We tend to enhance them. So give your patient some time to stabilize. After you've checked your treatment protocol, made sure that you've programmed what you intended to, if this patient has an immediate and early undercorrection, I would raise the flag that this might be someone who has a weaker cornea and watch them very carefully before you just lift the flap and do an enhancement. So can we trust the results of a computer model of a virtual eye? And so this is a process we call validation. What we did here was look at LASIK cases in our clinic in Cleveland and compared them to the simulated results. And we have a nice correlation here between the actual outcome and the predicted outcome, where we had just assumed the same properties for every eye, but we used patient-specific tomography and case-specific treatment variables. But what's interesting is we could improve those results and capture less predictive error if we included the preoperative corneal hysteresis as an adjustment. So this is a fairly coarse biomechanical variable, but it does tell us something about these eyes and their response to LASIK that can enhance the value of our predictive models. So again, the biomechanical measurement could be very important. Beyond a global property measurement like hysteresis, what if we can actually get spatial measurements like you've seen with Brion and OCT elastography? I think that can add a great deal of additional information that's going to add predictive value. I want to show you this example. We're following LASIK patients and actually SMILE patients now with this technique. And what you can see here is a relative stiffness map before LASIK and then after. And the biggest difference that you see here is a significant drop in the stiffness in the flap region, so the first 100 microns. So this is a fairly consistent finding in these eyes. And there's actually a slightly higher postoperative 3-month stiffness value in the posterior cornea. The rationale for SMILE, again, is that you're preserving those strong anterior fibers and removing a lenticule deep to that. Now, PRK is always going to have some advantage potentially, but again, it's removing some of these anterior interweaving fibers. We did a modeling study where we compared the stress distribution. We worked with Cindy Roberts on this. This is the preoperative state here, and the red shows that the stress is being borne primarily in the flap or cap region prior to surgery. The residual bed is what's on the bottom here, and there's not much stress in the residual bed. With LASIK, though, we see that the stresses can't be borne in the flap because the tension's been released, and so it shifts to the posterior bed, which is less well adapted to bear the stress over time. However, SMILE tends to preserve that anterior corneal stress and more or less buffers the posterior stroma from that. And again, that dip that we see with the LASIK flap would explain that. If we run this through a model, we take a patient and do a virtual experiment. What if we do LASIK? What if we do SMILE? And we look at the strain analysis. This is a postoperative strain on the bottom of the slide. There's a 15% increase in the strain with a SMILE or with a LASIK procedure of about 5 diopters. Watch this arrow for a SMILE procedure that's comparable, same correction, but about 11% increase in strain as opposed to 15. So SMILE, I think, does decrease the chances that we're going to destabilize a cornea. But there's one important assumption there, and I'll end on this. We assume that these corneas all have that normal property distribution that you've seen described. But we do know that in keratoconus, you start to lose these bridging fibrils, and that can happen most likely early in the process. So when we measure keratoconus patients, which we're in the process of writing up now, we see much lower anterior stromal strength than our normal eyes. And if we take that into the suspect population, LASIK still is going to have an advantage over SMILE, but as soon as we get into occult corneal weakness in the front of the cornea, the SMILE advantage may be lower and the PRK advantage will be higher. This may help explain why we see so little post-PRK ectasia. So my final slide, just a few pearls to take home. Remember that weaker corneas tend towards undercorrection of myopia. Monitor those for stability before you offer enhancement. Does SMILE have a structural advantage over LASIK? I would say yes in normal corneas, but PRK may be superior if there's occult anterior weakness. And so we need to understand this better and be able to measure it. The wait is over, I think, to start running simulations. There are several groups working on computational modeling software approaches to this. So what used to be a dream is becoming a reality. And then finally, there are some exciting emerging methods for measuring spatially resolved properties that might help us improve our capabilities. Thank you very much.